Hello, my name is Rusa. Here is my student ID. Today, I'm going to explain about the high priority clinical manifestations related to Mr. Birmingham based on the A to G assessment. As per the case scenario, there are several clinical manifestations that indicate the development of hypoxemic respiratory failure secondary to acute exacerbation of asthma. The high priority clinical manifestations related to Mr. Birmingham, which resulted in MED-call, are his SpO2 of 77% on room air, indicating severe hypoxemia, PaCO2 120 mmHg, indicating hypercapnia, respiratory rate elevated at 38 beats per minute, indicating tachypnea associated with serious respiratory distress. In addition, his audible wheeze indicates a serious asthma exacerbation. Moreover, his increased heart rate at 122 beats per minute indicate tachycardia with dry mucous membranes and soft murmur over the mitral area suggesting possible cardiovascular stress. Mr. Birmingham's GCS dropped down to 14, which means he is not fully oriented, which indicates possible hypoxemic encephalopathy. Similarly, his high temperature of 39.2 degrees Celsius suggests febrile, which is possibly related to an infection that can increase respiratory complication. Mr. Birmingham's inability to oral intake is associated with severe respiratory distress. Furthermore, his decreased lung sounds, right lower lobe, bilateral diffuse, high pitch wheeze, inspiratory and expiratory signals, the respiratory stress, and obstruction in the airway. Hence, these clinical manifestations highly indicate that Mr. Birmingham was going through serious respiratory distress that resulted in the med call for immediate medical attention. Thank you so much.
Hey, Rusha. My name is Anjana Poon, and here's my student ID. Here. Now, I would like to talk about the pathophysiological link between the identified high priority clinical manifestation and the disease condition that Mr. Birmingham has. From the given case study, he was diagnosed with hypoxemic respiratory failure secondary to acute exacerbation of asthma. With high morbidity and death rate, acute respiratory failure is a common medical condition that is seen in the emergency room. Patients who have an ARF are often tachypneic and their frequency of breathing increases and become hypoxemic. When a patient experiencing respiratory distress like acute asthma, it indicates severe respiratory muscle fatigue and higher risk of respiratory arrest. Elevated respiration rates can cause respiratory muscle exhaustion and demand a significant amount of labor. The RF mechanism is interconnected and respiratory illness that affect the lungs, causing more effort to breathe and more energy required. Infection, trauma, and drug overdose can also cause compromised breathing. To maintain ventilation permanent, constant, fast, and shallow breathing, these conditions can decrease tidal volume and it causes patients being tachypneic. From the arterial blood gas result, Mr. Birmingham partial pressure of oxygen is less than 60 millimeter of mercury, leading to hypoxemic respiratory failure. Low partial pressure of oxygen and low or normal partial pressure of carbon dioxide are often initial sign of hypoxemic respiratory failure. Reduced inspired oxygen pressure, which can happen at high altitudes, ventilation and perfusion mismatch, alveolar hypoventilation, or poor oxygen diffusion all can lead hypoxemic respiratory failure. It is caused by a variety of substantial respiratory changes, most commonly from alveolar collapse or consolidation, or from an accumulation of extra fluid in the lungs. Hypoxemia results from these changes because of the lung tissue unable to transmit oxygen across the alveolar membrane. Intrapulmonary shunting is a severe type of mismatch that happens when there is adequate perfusion but is incomplete ventilation of some lung tissue. The carbon dioxide level in this alveoli is higher and oxygen content is comparable to mixed in venous blood. When the condition is severe, the lungs will still receive ventilation, but there is little to no perfusion, which prevents gas exchange, which is referred to as dead space ventilation. There is also a shift in mental status, one of the indication of hypoxemic ARF, because the brain is highly susceptible of low oxygen level and acid-base imbalance. Likewise, tachycardia and mild hypertension is also an early sign indicator of ARF. This alteration shows the heart and muscles are trying to make up for dropping oxygen and increasing carbon dioxide level, as indicated in the case study. The blood result also showed the elevated CRP level, which indicates inflammation in the body, and there is a mild growth of bacteria called Pasteurella multocida, which is an infection from dog or cat bite or licking. This infection manifests as an acute inflammatory response with a quick onset. As an inflammatory response, the body temperature rises, and this inflammatory response is in respiratory health, highlights the potential benefits of both prevention of and therapy of conditions like asthma and COPD. Thank you.
Hello guys, my name is Kushi. This is my student ID, and today I will be talking about 2 diagnostic results for Mr. Birmingham and related to the underlying pathophysiology. According to the information provided in case study, 2 diagnostic results that indicate respiratory failure are ABG results and sputum result. ABG results indicate a decrease in pH and elevation in PaCO2, resulting in respiratory acidosis. Respiratory acidosis is usually triggered by inadequate levels of ventilation, buildup of carbon dioxide, a significant rise in the arterial partial pressure of carbon dioxide, in addition to a reduction in the ratio of arterial bicarbonate to arterial causes a drop in blood pH. In the human body, carbon dioxide plays an important role in regulating the pH level in bloodstream. In a normal state, body maintains the presence of CO2 by balancing its production and elimination. When it comes to the case of hyperventilation, there is an excessive production of CO2, and the body is unable to eliminate it, causing retention of carbon dioxide. This results in the increase of PaCO2 in the body. Moreover, the sputum results indicate moderate growth of the bacteria named Pasteurella multocida. These results signify bacterial infection. The bacterium is normally oral flora for several animals like dogs, cats, pigs. In a study, it was found that it is present in 50% of dog bite wounds and 75% in cat bites, and rarely from licks. The presence of this bacteria, along with the onset of asthma, can cause an additional inflammatory response. Respiratory diseases caused by Pasteurella multocida follows a relatively non-specific and includes shortness of breath, chest pain, narrowing of the airway, excessive mucus productions. These symptoms align with Mr. Birmingham's symptoms. Therefore, the inflammatory response, in addition to the pre-existing asthma aggravation, increases the risk of respiratory failure for Mr. Birmingham. Moving on, I will also talk about 2 medications that can be used to improve Mr. Birmingham's condition. One of the medications that we can use is magnesium sulfate, which is a bronchodilator. Administration of this medication results in a calcium receptor blocker and leads to the activation of adenyl cyclase, resulting in pulmonary smooth relaxation. Magnesium sulfate has bronchodilating effects that are achieved by blocking of calcium channels present in the airway, leading to the reduction in mucus, opening of the airway passage. Additionally, magnesium sulfate also results in an anti-inflammatory effect through multiple mechanisms, using eradication of the release of oxygen-free radicals, along with stabilization of T and mast cells. Moreover, it also helps in the release of indigenous nitric acid along with protostalin. The dosing of this medication is 2 grams every 20 minutes via IV, and it can be repeated twice. And the other drug that can be used to improve Mr. Birmingham's condition will be explained by Rusha.
Hi, I'm Manisha Negi, and this is my student ID. Now I'll be explaining the pathophysiological link between the multiple disease conditions that the deteriorating patient, which is Mr. Birmingham, has, and the clinical presentation. As the case study shows, Mr. Birmingham has a medical history of asthma, smoking, and eczema, which are the multiple disease conditions that are contributing to the deterioration of his condition. Patients suffering from asthma experience recurring episodes of acute exacerbation. This justifies the diagnosis of hypoxemic respiratory failure secondary to acute exacerbation of asthma, as Mr. Birmingham has a history of asthma. Triggers are responsible for worsening the health condition of the patient who has history of asthma. As you can see on the screen, the triggers which leads to the increased inflammation and structural changes. Triggers such as allergens, smoking, drugs, and infection are accountable for initiating inflammation, leading to the constriction of airways, resulting in dyspnea, cough, wheezing, and respiratory depression. These signs and symptoms can be persistent, which can make a person deteriorate and get hospitalized. Mr. Birmingham's case study is a great example of that. Furthermore, increased mucus production clogs airways and make sputum. Obstructed alveoli trap air, creating a ventilation perfusion mismatch. Blood enters the alveoli without air, due to which hypoxia is compensated by hyperventilation. Airway resistance increases during asthma exacerbation due to restricted airways. Alteration in airway resistance and lung compliance impact the effort required for breathing, leading to elevated oxygen consumption. People with asthma may present challenges for mechanical ventilation due to the combination of elevated positive pressures and increased resistance to airflow caused by airway blockage. The majority of people experiencing asthma attacks typically exhibit hypocapnia as a result of elevated respiratory rate. Smoking is another trigger leading to asthma and ultimately resulting in the signs and symptoms of asthma. Mr. Birmingham's medical history of smoking is another reason that led him to have asthma, which worsened his condition.
Now I'm going to explain about the one of the drug that can be used to improve Mr. Birmingham's clinical condition, which is salbutamol. It is the first-line treatment for acute exacerbation of asthma, also known as short-acting beta agonist. It is usually used to treat acute incidents of bronchospasm resulting from asthma, along with additional chronic bronchopulmonary diseases. Salbutamol helps to relax and smooth the muscles in the bronchial airway by providing instant bronchodilation. It is also known as one of the most useful and safest medication in the healthcare setting. Salbutamol assists to decrease the airway resistance and enhance the airflow that results in rapid comfort from bronchospasm. In the case of Mr. Birmingham, his serious respiratory distress, defined by shortness of breath, high-pitched wheeze, tachypnea, can be managed by using salbutamol via nebulizer. Nebulizers enable constant inhalation of the medicine. Salbutamol can be administered every 2.5 to 5 mg up to 4 times a day. Now another medication will be discussed by Khushi. This is it from me. Thank you.
This is the end of our presentation, and now I'll be showing the references that we use in our explanations. This is the third one, and all the reference has been put up together in the APA style referencing. Thank you.